Hey everyone, Ryan here, and welcome back to our Orthodontics series. So you may have noticed that we have a diagnosis and treatment planning video in most of our series for the different topics of the clinical board exam. And that's on purpose because it's really a staple in the health professions. We figure out what the problem is, we plan out how to fix it, and then we do our best to fix it. And that's what diagnosis and treatment planning is all about. In orthodontics, though, it looks a little bit different. So the full name of the specialty is Orthodontics and Dentofacial Orthopedics. So it's not only about straightening teeth, but also correcting malformations of the face. So it really boils down to bare basics, broad spectrum, both the teeth and the face. Dr. Proffit, Dr. Ackerman, and Dr. Sarver are known for redefining what orthodontics was all about in the context of the soft tissue paradigm. So the objectives of orthodontic treatment under this paradigm can be viewed as macro aesthetics, a beautiful face, mini aesthetics, a beautiful smile, and micro aesthetics, zooming all the way in for beautiful teeth. Now, Dr. Ackerman and Dr. Proffit went even further to represent 5 major characteristics of an orthodontic patient via a Venn diagram. So let's unpack what this is talking about. When diagnosing a patient, we can place our findings into these 5 categories: facial proportions and aesthetics, alignment and symmetry, transverse, anteroposterior, which I'll be referring to as AP for short, and vertical. Now, I would normally go through each one of these in more detail, one at a time, but it was challenging putting this material together because there's so much overlap among these 5 categories, as you can see in the Venn diagram. They are not clean-cut categories, so instead, keep these in the back of your mind, and as we go through the steps of an orthodontic exam, we'll fit things among one or more of these categories. So remember, we said before that orthodontics is all about the teeth and the face. And so if we really boil it down to the bare basics, our exam is focused on the teeth as part of an intraoral exam and the face as part of an extraoral exam. And then we also get some additional information from radiographs, particularly the cephalometric. So let's go through each one of these one at a time. So let's start with the teeth. So malocclusion is a very broad term. It refers to a bad bite. Now, malocclusion is not a disease, but a variation from what is considered ideal. Now, one of the most common factors of a malocclusion is some element of crowding, the teeth being bunched up together like people in a crowd, instead of straight along a nice arc. 15% of adolescents and adults have severe crowding. Much more than that are going to have some degree of mild to moderate crowding. And then some percentage of the population has spacing. Now, we talked in the last video about crowding being a math problem between tooth size and arch size. And we can think of it in the context of etiology, that crowding carries a genetic predisposition. There's some genetic predisposition to a discrepancy between tooth size and arch size. For etiology specifics, malocclusion has an unknown cause in about 60% of cases. The known cause is only in 5% of cases, and then that leaves 30 to 35% of the population with a normal occlusion. So if we move to the Edward Angle Molar Classification, we have 4 main categories here. So the first is normal class 1 occlusion. That's at 30 to 35% we saw in the last slide. A normal class 1 occlusion in the angle classification means that the mesiobuccal cusp of the maxillary first molar occludes with the mesiobuccal groove of the mandibular first molar, and the teeth are aligned along this line of occlusion that goes for both the maxillary and the mandibular arches. For a class 1 malocclusion, which is the most common one up here, we have that same angle class 1 molar relationship where that mesiobuccal cusp occludes with the buccal groove of the lower molar, but this time the teeth don't align along that line of occlusion, and there's some amount of crowding or perhaps spacing, some misalignment, rotated teeth, etc. For class 2 malocclusion, that means that the upper molar is too far forward and or the lower molar is too far back. So another way to think about it is that the maxillary arch is displaced mesially or anteriorly. The teeth may or may not be incorrectly aligned. Even if they were perfectly straight, and this was the molar relationship, we would call it a class 2 occlusion. Now we have subdivision 1 and subdivision 2 for the class 2 malocclusions. Subdivision 1 means that the upper incisors are flared forward or proclined. So these front teeth are either flared like this, they're proclined out, and we usually have some element of excess over jet. We'll talk more about that in the next slide. Subdivision 2 is where the upper incisors are more upright, kind of more like they're pictured in this image. They're standing up a little bit straighter, they're retroclined, they're upright. So in this case, you may or may not have this excess overjet in the front, but you will have some element of excess overbite. In class 3 malocclusion, the upper molar is too far back and or the lower molar is too far forward. Another way to think about this is that the maxillary arch is displaced posteriorly. Again, like class 2, the teeth may or may not be incorrectly aligned. This is the rarest form of malocclusion of these categories. So now we can talk about incisor overlap. And I know I've thrown out these terms overjet and overbite throughout the series. Now we finally get to unpack what exactly these mean. So overjet is defined as the horizontal overlap of incisors measured from the labial surface of the lower incisor to the labial surface of the upper incisor. So this image actually doesn't portray this accurately. The arrow should actually be going all the way up here. So normally the incisors, or the upper incisors overlap the lower incisors just by the thickness of their incisal edge. So if the upper incisor is coupled with or butting up right against this lower incisor as it should, they're contacting each other, the overjet should be about 2 to 3 millimeters, which is just this amount, this thickness of the upper incisal edge. So this image is, of course, depicting an excess overjet. Class 2 incisors, particularly what we would expect in a subdivision 1 malocclusion. The opposite of that is called reverse overjet, where the lower incisors are actually out in front of the upper incisors, and that would be a class 3 incisor relationship. Excess is much more prevalent than reverse. For overbite, that means the vertical overlap of the incisors. This is measured from incisal edge to incisal edge. So normally, the lower incisors should again contact the lingual surface of the upper incisors, but it should be at or above the cingulum, so somewhere in this region. This would create an overbite of about 1 to 2 millimeters. So this image is showing somewhat of a deep bite, which means we have excess overbite. The opposite of this is if we have some amount of vertical space between the upper and lower incisal edges, which is called open bite. Deep bite is much more prevalent than open bite. Next we have crossbites. So the first is anterior crossbite, and this refers to the maxillary anterior teeth being lingual to the mandibular anterior teeth. So actually another way to refer to this is reverse overjet, just like we talked about in the last slide, where those lower incisors are out in front of the upper incisors. Posterior crossbite is a little bit more complex. So this refers to some mismatch in horizontal overlap of the back teeth. So we know that the upper teeth should sit just outside the bottom teeth, overlapping kind of like a lid on a box. So if we're looking at the upper teeth, those upper molars are configured like this, and the lower molars should be just inside so that the lingual cusps of the upper molars are occluding in the central fossa of those lower molars. Posterior crossbite means that this is somehow messed up, and we'll look at those two situations here. So lingual posterior crossbite, which is the more typical example when we say posterior crossbite, is when the maxillary posterior teeth are lingual to the mandibular teeth. That's what we see in this example. They're located too far lingual relative to where those mandibular teeth are. So they still interlock, but they're in the wrong configuration. The other example of posterior crossbite, which is less common, is buccal posterior crossbite. And that's where the maxillary posterior teeth are buccal to the mandibular teeth. And that's what we see in this example. So they're completely buccal. This is sometimes called a Brody or a scissor bite, where those upper teeth sit fully outside the lower teeth, and it can really disrupt normal function with chewing specifically. So let's talk a little bit about the Bolton analysis. So this measures tooth size discrepancy by comparing the upper and the lower teeth. So there are accepted ratios between how wide the top teeth and how wide the bottom teeth should be relative to each other in order to get them to fit together properly. Again, to be the upper lid that fits snugly on the lower box. So we can have two mismatches here. The teeth can either be too large, and that's usually on the lower arch where the teeth are either the incisors, maybe some premolars, somewhere that teeth are just generally a little bit too large, and they may require interproximal reduction, or IPR. So this refers to slenderizing the teeth just a fraction of a millimeter between the proximal contacts with a strip to gain some minuscule but important amount of space. Again, that's usually done on the lower incisors. The teeth can also be too small, and they may require buildups. These could be in composite, veneers, or crowns. And the most common example of this are peg laterals. They don't even have to be quite this small, but they can be just slightly smaller than normal. And your Bolton analysis, where you measure all the mesiodistal widths and compare them with one another, could reveal that you have small upper lateral incisors, smaller premolars, and you may want to consider buildups to get all the teeth to fit together properly. So next, let's talk about the facial exam. So the face is really interesting. There are some proportions that we expect in a quote-unquote ideal configuration. So we can break the face up into vertical thirds, 3 roughly equal regions. The upper third goes from the hairline to the glabella, which is the most prominent part of the forehead. The middle third is from glabella to subnasale, which is the point just below the base of the nose. And the lower third goes from subnasale to menton, which is the bottom of the chin. Now, the measurement of the upper face can often be difficult due to variability in the hairline. But the good news is we can't change this dimension as orthodontists anyway, so that's probably the least important of the three. the most important is, of course, this lower third. Asymmetrical growth of the mandible will show in the lower third, and this is where we have the most influence. Ideally, in this lower third, the upper lip area composes the upper third of that lower third, and the lower lip and chin compose the lower 2/3 of that lower facial third. So we can even break that one further into smaller thirds. In a horizontal dimension, we can break the face into transverse fifths, so 5 roughly equal regions. And this is when it gets really cool. So the middle fifth goes from inner canthus to inner canthus. That's canthus means corner of the eye. The medial 2/5 go from inner canthus to outer canthus, so for her right and the left. And then the outer 2/5 go from outer canthus to the lateral helix of the ear, the outermost portion of the ear. And then the vertical line from the inner canthus point should be coincident with the alar base. So that's the sides of the nose. So that line should be coincident with the sides of the nose, which it is in this case. And not only that, but the vertical line from the outer canthus should be coincident with the gonial angles of the mandible, that part of that corner of the jawline there. And then the mid-pupillary distance, this is from pupil to pupil, should be the same distance and perfectly correlated with the commissures or the corners of the mouth. So if we were to draw lines down from there, they would be coincident with the corners of the mouth. So a cool way to remember these transverse fifths is going from right to left. We have an ear, an eye, the nose, an eye, an ear. So if you remember ear, eye, nose, eye, ear, you can probably piece together what all those fifths are in relationship to each other and to the locations of the face. So pretty cool breaking down the face into thirds and fifths. So next, let's talk a little bit about skeletal classification. So we talked about molar classification, we talked about how the incisors can be related to each other. Those were dental classifications. Now we're talking about skeletal classification and skeletal malocclusions, how the jaws are related to each other. So in class 1 skeletal occlusion, we're talking about the jaws being well related to N vertical. This is a vertical line dropped down from nasion, which we'll talk about later in the video when we get to cephalometrics. For now, this N vertical line is shown by this vertical red line out in front. So whereas dental classification has to do with the anteroposterior relationship of upper teeth to lower teeth, usually first molars, skeletal classification has to do with anteroposterior relationship of the upper jaw to the lower jaw. So in class 2 skeletal malocclusion, we have a prognathic or protrusive maxilla where the maxilla sticks out too far, or we have a retrognathic or retrusive mandible where that is too far back from the N vertical line, or we can have a combination of both. I included these two terms because retrognathic, retrusive, and prognathic, protrusive are sometimes used interchangeably, and they're basically synonymous. For class 3, we have the opposite problems. We have either a prognathic mandible or a retrognathic or retrusive maxilla, or some combination of both. These are not exact numbers here, but class 2, generally we have about 10% of people who have a protrusive maxilla. About 85% have this retrognathic mandible. That's the most common problem. That leaves about 5% that have a combination of both. And for class 3, we have This is 60% for retrusive maxilla. That's the most common. And then for prognathic mandible, that's about 20% of those patients. And then that leaves about 20% that have a combination of both. Again, those numbers are not too important for the board exam. What's probably most important here is that the retrusive elements are the most common for both of those malocclusions. All right, so we can continue to look from the profile view, this time looking more at soft tissues. So this is all about facial convexity. We're looking at the facial plane formed by glabella to subnasale to soft tissue pagonion, which is the chin point, the most anterior portion of the chin in soft tissue. I believe I touched on these before, but just to confirm, glabella is the area of the forehead that's typically most prominent. It's between the eyebrows, and the subnasale is the base of the nose. So for the facial convexity, we're basically drawing line segments from these 3 points and seeing how straight of a line that would be. So for a straight profile, if those line segments between glabella, base of nose, and chin point are going to basically form a straight line. You can see a straight line here, and the subnasale is a little bit in front of that, but that's hardly a few degrees off of that straight line. So anything that's generally under 10 degrees of a slight inclination, we're going to call a straight profile. And that's usually coincident with a class 1 occlusion, skeletal and dental occlusions. So a convex profile is where these line segments would form a convex curve. Maybe the subnasale is way out here, and or maybe the chin point's way back there. And of course it doesn't have to be that severe, but anything that's a little bit more than a 10-degree inclination, we're going to call convex. That's usually coincident with a class 2 malocclusion. Then concave is where the line segments form a concave curve. So subnasale might be back, chin point may be forward, something like that. And that's usually coincident with a class 3 occlusion. So facial divergence is rarely tested, but sometimes it does come up. It's similar to facial convexity, but it is slightly different. So I want to go over that discrepancy. So facial divergence refers to inclination of the lower face relative to where the forehead is. So a straight or no facial divergence, or straight divergence, I guess you could say, is very similar to what we just talked about with facial convexity. This is, you're going to drop a vertical line down from glabella, and subnasale and chin point are very close to that line. Posterior divergent means that the entire line dropped down from the forehead to the chin goes posteriorly. So subnasale is a little bit more posterior, and chin point's even more posterior. Anterior divergent means we drop that same line down, but this time subnasale is a little bit more forward, and chin point's even more forward. So it's not quite the same as convexity. This is talking about everything's kind of moving posteriorly when we go up to down. Everything's moving anteriorly as we go from up to down. Now the nice part about this is that this does usually fit with a class 2 malocclusion, as you could see, and this would usually coincide with a class 3 malocclusion. Now we can zoom in a little bit more on profile and talk about specific angles that are formed in the soft tissue. So the nasolabial angle is formed between the columella of the nose, that's this bottom part of the nose here that separates the two nostrils, and the philtrum, that's that vertical indentation of the upper lip. And that makes sense. This is naso for nose and labial for lip. So this angle should be approximately 90 degrees. It's determined by a bunch of different things: AP position of the maxilla, AP position of the upper incisors, and particularly vertical position of the nasal tip. Like if the nose is upturned in a younger child, that can make this nasolabial angle a lot larger, but there's quite a bit of range that is perfectly acceptable here. The thickness of the upper lip could also contribute to nasolabial angle. Moving down, mentolabial angle is between the lower lip and the chin. So mento for chin, labial for lip. This should be around 120 degrees. This one's affected by lower incisor position and vertical height of the lower facial third. It's sometimes also called mentolabial fold or mentolabial sulcus. And lastly, we have the cervico-mental angle. This one goes from menton, which is base of the chin again, to R point or reflex point, that's the depth of the throat, and then to the base of the neck. This one again, well, this one has a pretty large range. It goes from 90 degrees to up to 120 degrees. Major considerations of this one are gender, soft tissue sag from aging, and body weight. All right, so lips are arguably, if we're talking about the soft tissue paradigm, the most important soft tissue consideration of a modern orthodontist, outside of the gingiva and the periodontal tissues. So how I remember the lips are the 3 P's. That's position, posture, and proportions. So for lip position, we draw a line that's tangent to the nose and the chin. So this line right here, tangent to both of those 2 points, is called Rickett's E line or aesthetic line. So the lower lip should be on this line and the upper lip should be slightly behind the line. If both of your lips are ahead of the line, they're considered prominent or protrusive. If they're behind the line, they're considered retrusive. So that's a quick and dirty way of judging AP position of the lips. Note that this is not very useful if the nose and or chin are excessively large. This is most useful for patients in their adolescent years. So for lip posture, our second P, we're looking for lip competence at rest. So if we have 3 to 4 millimeters of separation at rest, which we see here, and mentalis strain on closure. So this means that in order for them to get a lip seal, they would have to strain their mentalis muscle. So we can see, I'll erase the drawing, so you can appreciate that amount of muscle strain of the mentalis. So the muscles have to tighten up to get the lips to seal over the teeth. So a combination of separation at rest and having to strain that mentalis to get the lips to close is lip incompetence. Lip competence means that the lips can form a seal over the teeth at rest without any amount of strain. For lip proportions, we're simply looking at their dimension. Are they thick and full, or are they thin and flat? How much vermilion, the actual lip tissue, do they display? So this one considers kind of all 3 planes of space. There's an AP component, a vertical component, and probably even a transverse component. For posture, this is pretty much a vertical issue. For position, it's pretty much an AP issue. So those are the 3 P's of the lips. Incisor display refers to how much of the incisors show either at rest or on smile. So incisor display at rest, we're looking for about 2 to 4 millimeters being aesthetically pleasing. So this is just a little bit of the incisor showing. Again, if you're at rest, maybe your lips are touching, you have lip seal, that's acceptable as well. On smile, we want all of the upper incisors to show with about 1 to 2 millimeters of gingiva above them. So that's not including the papilla area. We want a little bit amount of gingiva showing above those teeth. That's a youthful look. Any more than 2 millimeters is considered a gummy smile by the layperson. About 75% of the incisors showing on smile is considered the minimum acceptable amount. And finally, buccal corridors. So this refers to the dark space between the maxillary posterior teeth and the corner of the mouth upon smile. So that's this amount of negative space, sometimes it's referred to. If you have a collapsed narrow arch form, it can result in a lot of shadowing, negative space, referred to as wide buccal corridors. Having treatment that involves lateral expansion of the premolars and molars into this space can improve the transverse smile dimension and create a more medium or even narrow buccal corridors if there is minimal dark space in those corners of the mouth. So a broad arch will result in narrow buccal corridors, while a narrow arch will result in wide buccal corridors. And the last part we'll talk about are cephalometrics, which look at both the teeth and the face in a very unique perspective. So the lateral cephalometric gives us a lot of information about a patient's hard tissue as well as soft tissue structures from the profile view. So I've marked a bunch of cephalometric landmarks here that we can go over together. So our first one we'll talk about is this one back here. It's not very commonly used, but it's called the Bolton point, and that's BO for short. It's the highest point in the upward curvature of the occipital bone at around the center of this gigantic foramen magnum where the spinal cord runs from the brain down here. Next, we have the basion, which is this point right here. That's BA for short. And the basion is the lowest point of the anterior margin of the foramen magnum. And it points towards the dens, or the odontoid process, which is right here, of C2. That's the axis of the vertebrae. And we'll talk a little bit more about vertebrae in a little bit. The next point is the articulari, AR for short, and that's right here. That's the intersection between the zygomatic arch, which is running here, and the posterior border of the ramus. Note that there's actually, you can see both rami. You can see one here and then one further back here. And this means that the patient was either, there's some degree of asymmetry between the right and left sides, or probably more possible, the patient wasn't positioned properly in the imaging unit. So in that case, we just split the difference between the left and right sides, and we pick in the middle of those two projections. Next point is the porion, which is up here, PO for short, and that's the highest point of the external auditory meatus. That's the outer ear opening. And this part is the ear rod of the cephalometric machine. So we would imagine that's pretty close to porion, which is the outer ear hole in the skull. So next, let's go to this one. That's condylion, CO, and it's the most posterior and superior point on the outline of the condylar head. The condyle can be pretty tough to see in a cephalometric. Next, we'll go over here. This is the pterygomaxillary fissure, PTM, and that's the base of this fissure. It's often a teardrop shape that runs along the back of the maxilla. A bunch of vessels and nerves run in and out of that fissure. Next, we'll go up here. This is sella, S for short. It's the midpoint of the sella turcica, which is the saddle in which the pituitary gland lives. This point over here is orbitale, OR. That's the lowest point on the inferior margin of the orbit, where the eye lives. Up here is nasion, or N, and that's the anterior point on the intersection between the nasal bone down here and the frontal bone up here. And you can almost appreciate the little suture running here between those two bones, which is pretty cool. All right, next let's go here. This point is the anterior nasal spine, and that's the sharp projection of the maxilla anteriorly. And then we have the posterior nasal spine, which is usually right below the PTM, and that's the sharp projection of the palatine bones posteriorly. That's where that hard palate ends. Right here we have a point, and that's the innermost point on the contour of the maxilla. That's the innermost point on the contour of the maxillary bone. Likewise, we have the B point, which again is the innermost point on the contour of the mandibular bone. Down here we have three right up next to each other. This one is pagonion. That's the most anterior point of the chin. You may remember we had a soft tissue pagonion, which is the soft tissue counterpoint to this hard tissue landmark. Down here we have menton, which is ME for short. That's the most inferior point on the chin. Again, we have the soft tissue menton, which we talked about before when we were talking about facial thirds and other things. And the point between pagonion and menton is called gnathion, and GN are the letters there. Gonion is back here. That's GO. That's the midpoint on the contour connecting the ramus and the body of the mandible. And I believe that's all the points we have here. Other structures to point out, we have the frontal sinus up here, the ethmoid air cells, we have the maxillary sinus, this gigantic thing here, the sphenoid sinus, the mastoid air cells. Here is C1, which is the atlas, C2 with the dens running up here. That's the axis. We have C3, C4, and we can keep going down. This is the hyoid bone right in here, the epiglottis here, and of course we can appreciate the soft tissue profile with the nose, the lips, and the chin. So lots of stuff to get from a cephalometric x-ray and some really cool stuff there. Here's a summary of everything that we just talked about. So from those points, we can gather some important information, like reference planes that connect two of those points together. For example, we could connect sella and nasion and get the SN plane, which represents the anterior cranial base. If we connect porion and orbitale, we get what's called the Frankfurt horizontal plane, which is an incredibly important reference plane. If we connect ANS and PNS, we get the palatal plane. If we connect lower 6, which is the cusp tip of the lower first molar, and lower 1, the incisal edge of the lower incisor, we get occlusal plane. And if we connect gonion and gnathion, we get the mandibular plane, which is another really, really important reference plane. The Sassoon analysis states that all 5 of these reference planes should intersect at around the back of the head, the occiput of the head. If they intersect earlier, the patient is considered hyperdivergent. If they intersect later, they're considered hypodivergent. Just one example of how these reference planes can be used diagnostically. So probably the most important use of the cephalometric is a cephalometric analysis. This is used to evaluate the relationship of the jaws and the dental units to each other. This used to be done on acetate paper, but today we use computer software and mark all of those landmarks we just went over, and then the software would develop a tracing from which you can gather all these linear and angular measurements. These measurements allow you to evaluate the relationship of the jaws and the teeth to each other and the cranial base to which everything is attached. And you would compare your patient to numerical norms for their age, racial, and ethnic groups. So SNA is a very common angular measurement. This is the angle from sella to nasion to A point, and it represents the relationship of the maxilla to the cranial base. A bigger angle means that the maxilla is further forward. A smaller angle means that the maxilla is further back. SNB, sella to nasion to B point, refers to the relationship of the mandible to the cranial base. A bigger angle means the mandible's more forward. Smaller angle means the mandible's further back. And then A and B kind of combines those two together, and this instead looks at the relationship of the maxilla to the mandible. And this is the one that comes up on the board exam quite frequently. So we go from A point to nasion to B point. And this angle is very, very small. If we're at around 0 degrees or below, we're in the negatives, that is considered a class 3 skeletal malocclusion. Because again, we're talking about the jaw units. We're not looking specifically at what the teeth are doing. So 0 or below, class 3. Around 2 degrees is considered normal. 4 degrees or above is considered class 2. So this is what will most likely come up on the board exam. They'll give you an angle, and if it's 0 or below, class 3, 4 or above, class 2, and if it's somewhere between 0 and 4, that's a normal class 1 skeletal relationship. And the last diagnostic thing we can do with cephalometrics is to superimpose them. So we superimpose or overlap cephalometric tracings from different time points on top of each other to see what has changed. So this could be to evaluate growth changes over time or to see what the effects of treatment were, either orthodontics or orthodontic surgery. All right, so that's it for this video. Thank you so much for watching, everyone. I know it was a long one, but there's a lot of good information in there, and I wanted to make sure we included all of it. So please like this video if you enjoyed it, and subscribe to this channel for much more on dentistry. If you're interested in supporting this channel and what I do, please check out my Patreon page. Thank you to all of my patrons for all of their support. You can unlock extras like access to my video slides to take notes on, and practice questions for the board exams, so go check that out. The link is in the description. Thanks again for watching, everyone. I'll see you in the next video.